thank you all for coming, and especially thanks to Dr. Riaz Chowdhury. Riaz bhai, very close to us, and he already gave a very nice lecture on acute pancreatitis in past. We are very proud of Riaz bhai. Riaz used to be the president of Bangladesh Medical Association of North America. Beside his leadership role in our organization, also he is playing a leadership role where he works. He's associate professor of University of North Carolina, Chapel Hill, as well as he is the chief of gastroenterology in the hospital where he's working right now, which is Wake Medical Center in Raleigh, North Carolina. Riaz Chowdhury, Riaz bhai, also very efficient in advanced endoscopic tests, including endoscopic ultrasonogram and biliary procedure, ERCP. He is doing it for a long time, and he mentored many physicians. And we're really looking forward to hear more about the management of acute pancreatitis, the role of those, and the common causes. Now, I will not wait. Before we started, as we said before, we have a disclosure that these programs are, we are doing it with the help of United Healthcare, United Hospital, and also the INSEPTA, but we do not have any financial relationship with them. All of our faculty and directors, we do not receive any kind of monetary benefit from them. This is completely voluntary work we're doing, but we're very grateful to INSEPTA and United Hospital for helping us to make it possible for all of our programs. And all the attendings, whoever is joining today, I would like to say thanks to them, and please join in our lecture.
Shall we start? Can you see my screen?
Yes.
Okay. Thank you, everybody. Shobaike salam, এবং thank you, Atik, for the nice introduction. So I'll talk about just how do we manage acute pancreatitis, and I'll try to be focused with recent development in that area. So acute pancreatitis, as you all know, that is just an inflammatory condition of the pancreas, but it can cause local injury, systemic injury, and inflammatory response syndrome, as well as organ failure. So it's not like a localized disease, and it starts locally, then it causes, systemic inflammatory response syndrome and organ failure. Worldwide is a common gastro GI condition, but with a substantial number of suffering, morbidity, and cost to the healthcare system. In America, 2019, there was 275,000 patients admitted to the hospital with this problem. And the average cost to treat this disease is $2.6 billion per year. So it's a deadly disease, and it can be, better managed. And the mortality rate is quite high in some cases. And it's inexpensive. And I'll try to gear the management part, but before we go, we need to update ourselves with any disease regarding the etiology, pathogenesis, and clinical features. Like on this topic today, I'll talk about the drug-induced pancreatitis. There are some new drug, GLP-1, that has been FDA warning regarding the etiology. I'll also talk briefly about the post ERCP pancreatitis. This is done by us, iatrogenic, and is a trauma happened during the ERCP. So I'll talk about how to manage and how to prevent. I'll talk about the management of acute pancreatitis, and I'll talk about the new entity of acute pancreatitis, that is the autoimmune pancreatitis. Then I'll talk about the role of antibiotics, and then I'll talk about the gruesome complication like, pancreatic fluid collection, necrotizing pancreatitis. Everybody get very worried about that and how to manage that, and also talk about the nutrition during the management of acute pancreatitis, which has really, really significant role. So just on one slide, regarding the etiology, as we all know, the Western world, the gallstones is still the leading cause of acute pancreatitis, about 40 to 70% cases. Second, in alcohol, 25 to 35%. And the third variety is idiopathic, when we could not find a cause, but that basket is getting smaller as because we are finding more and more causes, as I'll come later on. Drugs is an important cause. Hyperlipidemia is an increasing challenge, especially hypertriglyceridemic pancreatitis. Hypercalcemia is decreasing, but this is a definite cause. Any kind of infection in immunocompromised patient can cause pancreatitis. Trauma, we are level 1 trauma center. Per year, we get around 10 patients who had a blunt abdominal trauma and pancreatic ductal disruption with acute pancreatitis. And as I said before, ERCP is a cause of acute pancreatitis. Hereditary pancreatitis is a very well-defined disease, and obstruction is an important cause. About 5% of the pancreatic malignancy present with acute pancreatitis. And it also may happen from ampullary stenosis, pancreas divisum, so those kind of etiology. Postoperative status, hypotension, they may cause. And a scorpion venom, I never had a case, but it has been mentioned as a cause of acute pancreatitis. And I think the tropical chronic pancreatitis may present with acute pancreatitis. As my presentation is focused with this Western world, I think, I don't have much, data on that. So I'll briefly talk about the gallstones pancreatitis, just one slide. As I said, the commonest cause of acute pancreatitis, and gallstone does not cause chronic pancreatitis. That is also about, trivia. So gallstone does not cause chronic pancreatitis, but it is an established commonest cause of acute pancreatitis. There is one study that did show if a patient has a liver function test with acute pancreatitis with ALT value more than 3 times normal, you can say with 95% accuracy the patient pancreatitis is secondary to gallstone. And another thing, we expect the size of the stone, if it is bigger, actually the bigger stone cause less pancreatitis. They may cause more obstructive feature like cholangitis. Usually the smaller stone, even less than 5 millimeter, even biliary sludge like microlithiasis, they may cause acute pancreatitis. So size, smaller size, more chance that they will block the ampulla and cause acute pancreatitis. And we can just simply, everybody has an LFT done. And if it is more than 3 times, we can pretty much predict that the acute pancreatitis is secondary to gallstone. Alcohol-induced acute pancreatitis is a whole day talk, but I'll just talk about 2 landmark paper to how regarding the alcohol-induced acute pancreatitis. So one is the Archive of Internal Medicine. A study showed that abstinence from alcohol alone doesn't work. Tobacco, smoking, and alcohol, they go along, and together there is really a toxic brew. So if you wanted to patient alcoholic acute pancreatitis, you have to counsel them about both alcohol and tobacco cessation. Second paper is, say after having an acute pancreatitis, if they don't have any structured follow-up with primary care doctor, they will come back again within 1 month or 2 months. So a study also showed that a 6 months interval follow-up with primary care physician to follow that alcohol abstinence and support, that really helps. Otherwise, it will continue. That's the 2 slides I chose regarding the alcohol-induced acute pancreatitis. So post ERCP pancreatitis is an universal problem. It happens every country. And Paul Freeman is one of the guru, and he did a meta-analysis and found for the gastroenterologists that which patients are prone to have post-ERCP pancreatitis. So if someone had a prior history of post-ERCP pancreatitis, that is likely that the patient will develop again. Second thing, if the patient has suspected, we call it SOD, sphincter of OD dysfunction. they're likely to have post ERCP pancreatitis. And sphincterophory dysfunction, whether that exists or not, that disease is kind of irritable bowel syndrome type of things, like biliary dyskinesia and ampullary spasm, that kind of disease. So if you do ERCP on this patient, you have to be very careful. Female gender overall has been found that a meta-analysis that are at a high risk for post ERCP pancreatitis. If someone had a normal serum bilirubin, that means they have a normal LFT, they don't have any biliary pathology. So they're at high risk for post ERCP pancreatitis. The good thing is presence of chronic pancreatitis is a safeguard. They don't develop an post ERCP pancreatitis as because their pancreas is already sick. So absence of chronic pancreatitis is a risk factor. Presence is a negative factor. Biliary sphincter balloon dilatation. We often do that when there is a large, periampullary diverticulum. We cannot do adequate sphincterotomy, so we do dilate the sphincter with balloon, and that is also a risk factor. And difficult cannulation is, ERCP may run from 10 minutes to 2 hours. Some people had really difficult, anatomy, and that is also risk factors. If we had to do pancreatic sphincterotomy, like to remove the stone from the pancreatic duct, which is very common in a tropical chronic pancreatitis. When it blocked, we do the pancreatic sphincterotomy, and that is also a risk factor. So these 8 risk factors has to be reviewed before you do post ERCP pancreatitis, as because in America, post ERCP pancreatitis is one of the legal challenge. Most of the lawsuit happens regarding this. So patient needs to be well aware that risk it may happen. And actually, post ERCP pancreatitis can be very severe also. How to avoid post ERCP pancreatitis? So the best tool to avoid is don't do ERCP as a diagnostic tool. So ERCP is no longer a diagnostic fishing tool like used to be before. ERCP is a very fancy procedure for gastroenterologists. At the beginning, we used to do it to see there is a stone or to see is there any other biliary pathology. So it is completely no longer should be used as a diagnostic tool. Use other diagnostic tool like endoscopic ultrasonogram. I do, if there is a suspected stone, I do an EUS, and if there is a stone, then I'll proceed with ERCP. MRCP is available, is also a wonderful tool. And if nothing is available, but you suspect the patient might have a stone, let the surgeon do the gallbladder surgery, and they can put some dye in the through the cystic duct. We call it intraoperative cholangiogram. And if there is a stone seen, then do the ERCP. So the established rule is avoidance ERCP if alternative diagnostic tool available is the best way to avoid post-ERCP pancreatitis. And is there any proven therapy for post-ERCP pancreatitis? Like different medication have been tried, like Gabexet is a protease inhibitor, corticosteroid, then indomethacin, ulinastatin, even heparin was used, and it was presumed that microthrombi may cause, pancreatitis. And the correct answer, this is like true GI board questions. So the correct answer is indomethacin. Indomethacin has been shown effective in preventing post-ERCP pancreatitis. This is another landmark paper published in New England Journal of Medicine. And they did show that a statistically significant improvement between placebo and indomethacin group in regard to the post-ERCP pancreatitis. And also, moderate severe pancreatitis is much lower when you give indomethacin. And the side effects is very negligible. GI bleeding may happen, renal failure may happen. But you all know that if the patient see bleeding during the ERCP, we don't give indomethacin. And if the patient has renal failure, we don't give them. But I routinely give, indomethacin is a rectal suppository. It's very cheap, like 100 milligram of indomethacin. And it's immediately after the procedure. I do all my ERCP now on the supine position. No longer, in America, we do ERCP on the prone. position, which was used to be. Prone position is easy, even you can give it during the procedure. So I do immediately after procedure, I do an indomethacin suppository. And it has been shown to decrease post ERCP pancreatitis. Another tools I use sometimes, the pancreatic stenting. And this is also another meta-analysis, well done. And you can see that it's all in favor. If you put a pancreatic ductal stent, that prevent post ERCP pancreatitis. But most of those patients, they may require an EGD to remove that stent after 3 to 5 days. And it may fail off by itself, but if 60% cases, it does not. And our goal is to keep it in there so the pancreatic duct can be drained. So this is the disadvantage. And so it's the judgment. If I work on the pancreatic duct longer time, bigger stone removal, and then, stricture dilatation, then I do give both indomethacin and put an stent. If I do the biliary work, then I just give indomethacin, not the stenting. Next topic, as I said, is in America increasingly common cause, like hypertriglyceridemia and pancreatitis. This is another study done by Amar Nijed Shikhok, Phil Toskos, who was the president of American Gastro Association and the dean and head of GI at University of Florida. And he actually did main work on that. And actually 3 to 5% cases in America is secondary to hypertriglyceridemia. But you have to have a very high level of hypertriglyceridemia, like it has to be more than 1,000 milligram percentage. 500 milligram level may cause abdominal pain. And if they had any of the other drugs which cause hypertriglyceridemia, like beta blocker, thiazide, if they drink alcohol, if they take birth control pill, that may trigger them to have acute pancreatitis from 500 range to 1,000 milligram. So if someone had a hypertriglyceridemia, you have to cautious with this medication, and it has to be very high level. A couple of weeks ago, I did consult in Bangladesh, one patient from United, triglyceride level was more than 4,000. One of my relative, Dr. Mahabub, took care of her. And initially they said idiopathic, and she's a female, doesn't drink. Then I said, check the triglyceride level. And it was like 36,000, And it's a hereditary problem in Bangladeshi community. A lot of studies showed hypertriglyceridemia is very common among us, So you have to consider that. And another very important thing regarding hypertriglyceridemic pancreatitis, as I learned that the amylase and lipase may not be that significantly elevated. And so this is the problem. Patient had abdominal pain. If you do a sonogram or CT, you may see stranding around the head of the pancreas, but amylase lipase may not be elevated. So this is two things comes into mind when you are suspicious for acute pancreatitis, but amylase lipase is not that elevated. Either they may have hypertriglyceridemic pancreatitis or there is a pancreatic malignancy. The CT and sonogram changes could be secondary to malignant stranding rather than acute pancreatitis stranding, and the pain would be similar as acute pancreatitis. So cautious about high suspicion for acute pancreatitis, and when the amylase lipase doesn't support your diagnosis, think about two possibilities: hypertriglyceridemic pancreatitis as well as underlying a small pancreatic ductal malignancy. So drug-induced pancreatitis, is every resident and a physician should ask about these drugs during the H&P. And I always teach my fellows that, every acute pancreatitis is present, I specifically check whether they're asking about the drug-induced pancreatitis. So the blue panel shows the definite causes, and the white panel, the possible causes. Definite cause, again, the medication we used to use more for IBD, like azathioprine and 6-MP. And estrogen is a cause of acute pancreatitis, and not the progesterone. That is also board question: does progesterone cause acute pancreatitis? Valproic acid, we don't use that anymore. for seizure disorder, that is a definite cause. Pentamidine and DDI, DDC, that anti-HIV medication used, they are definite cause of acute pancreatitis. Two important and common drugs like thiazides and Lasix, they are definite cause of acute pancreatitis. Sulfonamides and NSAIDs may cause acute pancreatitis, definitely. Possible causes are asparagines, AC inhibitor, lisinopril is also, it is almost definite cause. 5-aminosalicylic acids is also a possible cause of drug-induced pancreatitis. And the GLP-1 agonist is the last 3 months ago, this huge, this is a revolutionary drug in diabetic management. And I think, there are different, this group is increasing day by day, like exenatide, liraglutide, sitagliptin, these are the pharmacological name. And they are increasing cause of acute pancreatitis, and FDA put in a warning. And they actually decrease pancreatic secretion. So pancreatic juice get very concentrated and cause acute pancreatitis. So be aware of these drugs and which cause acute pancreatitis. So how, the second question, my fellows always ask, how do they cause acute pancreatitis? So different mechanism. Immunologic mechanism is the commonest, like 6-MP, aminosalicylic acid, sulfonamides. They cause immunologic pathogenetic way, and the patient may develop a rash. You may find eosinophilia, and usually 3 to 4 weeks time takes to develop acute pancreatitis. Diuretics, thiazides and Lasix and sulfonamides also has a direct toxic effects. Third possible mechanism, accumulation of toxic metabolite, and most likely HIV medication like DDI, pentamidine, valproic acid, they cause, accumulation. And that accumulation, this group usually develops after 3 to 6 months. It's not like immunologic, so it keeps on developing there to a toxic level and cause acute pancreatitis. Ischemia, like, diuretics may cause ischemia and may cause. And intravascular thrombosis, the pathogenetic mechanism for estrogen to cause acute pancreatitis. So the another etiology is hereditary pancreatitis. This is a very sad disease, and one of my mentor, Dr. David Whitcomb, he was my mentor, my teacher, and he actually invented this disease. And he spent, his life in a genetic lab, although he's a gastroenterologist, but he's a very basic science. And actually, it's very interesting, this is now the model of learning how acute pancreatitis happens. So hereditary pancreatitis is an autosomal dominant hereditary condition, and there is a cationic trypsinogen gene mutation in two sites. So how does it work? Normal person, everybody secretes some trypsin, and the trypsin in this group, and trypsin is the triggering factor for acute pancreatitis. But we also have a trypsin inhibitor secretes in the pancreatic juice, and that hydrolyzes the trypsin. So we all have trypsin secretion in the pancreas, and we also have a trypsin inhibitor, which hydrolyzes the trypsin, so we don't develop acute pancreatitis. These kids, they have the defective trypsin, so that trypsin cannot be hydrolyzed by the trypsin inhibitor. So they keeps on accumulation, the mutated trypsin in the pancreas, and cause acute pancreatitis. Usually start around the second decade of life, and this is a very painful condition. I have a couple of patients, and it's very sad story. These kids have recurrent acute pancreatitis, and ultimately they had chronic pancreatitis. And they all get very frustrated, and they start smoking, drinking also. The one important thing is lifetime risk for pancreatic cancer in this group is more than 40%. You see, lifetime, they do develop pancreatic malignancy. So currently, we follow them every year with an EUS or pancreatic MRI, and they will end up having total pancreatectomy with islet cell transplant. That's because it's a very painful condition, and usually by second and third decade, they will have total pancreatectomy and islet cell transplant to prevent diabetes. So this is a very well understood disease, hereditary pancreatitis. And the new entity is autoimmune pancreatitis. This is also a landmark paper in New England Journal of Medicine. There are great deal of attention. Initially this disease was reported in Japan and Belgium, actually in Europe, and Americans kind of denying that it exists. Then when the disease has been more published data from Belgium and Japan, then what happened in America, like Mayo Clinic and Harvard Medical School, they went back to their pathology lab and find out the whipples, like total pancreatic surgery they did, and which did not show malignancy. Usually autoimmune pancreatitis present like a pancreatic head malignancy, head of the pancreatic mass, biliary dilatation, multiple lymph nodes. And so they went back to the pathology specimen to see. We know that we often have that, surgery and no malignancy was seen. And they retrospectively found that all of those patients had actually acute and autoimmune pancreatitis. So this is a disease can be treatable very, satisfactorily. That's why I wanted to say, although very rare, it's very rare. I have totally, like 5 cases so far. I diagnosed them. You need to do a true cut pancreatic biopsy through the EUS. Fine needle aspiration actually does not make the diagnosis. And it is secondary to an IgG4 antibody and also a pancreatic basic protein. Those are the blood tests we can do. They cause diffuse enlargement of the pancreas, head of pancreatic mass, biliary and pancreatic ductal stricture. Now, we also found that actually there is a 2 subtype. One is known as type 1 autoimmune pancreatitis. Another one is type 2 autoimmune pancreatitis. And these are completely different disease, as you can see from that slide. Type 1 usually happen in elderly population. Type 2 happens in the 4th and 5th decade, 40, 50. Surprisingly, this is an autoimmune disease, but it's not more common in female like other autoimmune disease. It's more common in male type 1, type 2 is equal. Serum IgG level will be elevated 2/3 cases in type 1. Type 2 is like 1/4 cases. But type 2 has association with IBD, like Crohn's disease, ulcerative colitis patient, 10 to 20% cases, it will be associated. And type 1 disease has IgG-related disease. There is a new disease entity like parotid gland lymphoma, salivary gland tumor, and stricture in the retroperitoneal fibrosis and biliary pancreatic stricture. We call it an IgG4-related disease. So type 1 will be associated with that. Type 2 will be associated with IBD in 10 to 20% cases. And histologically, there is 2 characteristic finding, we can differentiate this disease. And the main good news is response to steroid is 100%. I usually use high dose 40 to 60 milligram of steroid for 3 months, then taper them, over another 3 months. But relapse is very common in type 1. Up to 60% of the patient may require immunosuppressive therapy after if the steroid fail, like 6-MP, azathioprine. And more studies are going with other cell-safe, even the biological therapy like Remicade, they have also been given trial. Type 2 usually is very well done. Relapse rate is very low. So I have an interesting story. One weekend I had a 50-year-old female who, like it was a Friday afternoon, came with obstructive jaundice. Her bilirubin was 26. And this is a recent patient. CT scan showed, 4 centimeter mass in the head of the pancreas. Common bile duct was, blocked. There was multiple peripancreatic lymphadenopathy. So the clinical suspicion was like head of the pancreatic malignancy with biliary obstruction. So I did an EUS, and I did indeed, I see there is a mass and multiple peripancreatic lymph node. I did FNA. And it was the Friday afternoon, so I don't have the pathologist to come in the room. So I did blind FNA biopsy. Then I did an ERCP, and I put in a stent. And she was only 46, and I talked to the husband that most likely malignancy. And they're all tearful, she had 3 children. And the Monday morning, the pathologist called me and said, Riaz, there was no malignant cells, I did also brushing, but we do see some lymphocytes, are you sure that you did a pancreatic head malignancy or you did lymph node? I said, I did both. And I said, they just look like a couple of lymphocytes, but no malignancy at all. They did the IgG4 staining and said it could, this is remarkable. Then I treated, convinced them that it's probably not malignancy that make them happy. Then after 1 week, I brought her back and did a true cut pancreatic head mass biopsy. And that confirmed autoimmune pancreatitis type 2. And then I treated her with prednisone. And 3 months later, I found that, the mass has been decreased now to 1 centimeter. All the lymph nodes are gone. So I continued another 2 months in tapered dose. Clinically, she's fine. I removed the stent. Her stricture went away. So this is a very satisfactory, and good story for the patient. So always keep in mind, that autoimmune pancreatitis is a disease. I don't know the study or Bangladesh, how common is it, but it does exist. It just simulates as a pancreatic head malignancy. And until unless you do true cut biopsy and you can do the IgG4 level to diagnose those groups. And the last variety is the idiopathic pancreatitis, which used to be 10 to 18%. Now, extensive research found that actually cystic fibrosis, CFTR mutation, they actually cause acute pancreatitis also. So cystic fibrosis, they have multiple mutation in cystic fibrosis. Some mutation, they may cause acute pancreatitis, and which we used to call idiopathic, found that is a good group, actually has underlying cystic fibrosis. But my message is no patient should be allowed to be called idiopathic pancreatitis, if their age is more than 50, until unless they have a good pancreatic protocol, CT or EOS, because you may miss malignancy. We may not see any cause, and there may be a small tumor there. As I mentioned earlier, 5% of malignancy may present as acute pancreatitis, and in that group, they are actually resectable. So before calling idiopathic, we make sure that we had a good pancreatic exam and make sure they don't have a small tumor in the pancreatic duct. Now, I'll go straight to the management part of acute pancreatitis. So is there any therapy for acute pancreatitis? So multiple medication has been tried, like lexipefant, octreotide, glucagon, H2 blocker. And in Japan, they use multiple protease inhibitor, but the correct answer is none of the above. So this is a fatal disease, but we don't have any treatment. So I always teach my resident and fellows, I go by the errors in management. So we can remember the tricky area of the management. We don't make any, like a mismanagement of acute pancreatitis. It's because acute pancreatitis management can be very life-saving if you do timely intervention. So first and foremost, we need to identify the severity of the disease. So first thing I always teach my resident, I wanted to see in their HNP, they did disease severity stratification. So there's a very simple method now. I no longer use that Apache score or Ransom's criteria, which has been historically but it's not clinically feasible. So I go, this is a revised Atlanta Symposium, 2013. The pancreatitis group met, and we found that we can classify pancreatitis initially. Say you patient in the emergency room, we can only classify whether the patient has a mild or moderately severe acute pancreatitis. What are the criteria? Is there any features of organ failure or SIRS, systemic inflammatory response syndrome? Do they have tachypnea? Do they have tachycardia? Do they have any hypoxia? Do they have any impairment? So it can be easily, clinically, you can see whether the patient has. And everybody has a sonogram or CT if there are any local complication, like a pancreatic fluid collection, a stranding around the pancreas, pancreatic abscess or cyst. Is there any local complication? So if there is no local complication, no organ failure, we can safely call them mild acute pancreatitis. And if there any local complication and or if there any organ failure, we can call them moderately severe acute pancreatitis. And if the organ failure, it has to be more than 48 hours, then we call it severe acute pancreatitis. So these, the message here, we have to identify moderately severe acute pancreatitis right in the emergency room so we can monitor them in a monitored bed, not in a floor where they are not monitored, their tachypnea, their SIRS, their renal function. As because, all acute pancreatitis start as a edematous interstitial pancreatitis, and eventually they go into the necrotizing pancreatitis. So it's very important to identify the moderately severe acute pancreatitis and put them in a monitored bed. So simply, the disease stratification is the number one thing. You have to identify mild and moderately severe acute pancreatitis and follow them. And our goal is to prevent severe acute pancreatitis within 48 hours. Next error in management is failing to prevent necrosis. How do you do aggressive intravenous hydration? So as I mentioned, all acute pancreatitis starts as just an edematous acute pancreatitis. What happened, in acute pancreatitis, there is around 8 to 10 liters of sequestration of fluid into the peritoneal cavity. So there is a huge intravascular volume loss, and there is hemoconcentration, and the hemoconcentration lead to the decreased perfusion in the pancreas and cause necrotizing pancreatitis. And our goal is to break that cycle with IV fluid. So IV fluid at this point is the only established treatment of acute pancreatitis. Our goal to start IV fluid as soon as we see the patient in the emergency room to prevent, is not a treatment of acute, whatever damage happened, to prevent the development of necrosis, to prevent the hypoperfusion in the pancreas. This is a very essential step. And in America, it is a routine protocol, and the number of necrotizing pancreatitis is decreasing as because we start IV fluid very, very generously to break the cycle. So next question is, which IV fluid you will use? So actually, you can use both normal saline, but the preferred fluid is lactated Ringer solution. We call it ELA. There is also science, as because if you give too much normal saline, there are some metabolic acidosis happens. Acidosis cause more acinar cell damage. That's why the preferred fluid, IV fluid, is ELA, lactated Ringer solution. How much fluid should we give? So American College of Gastroenterology defined that as an aggressive hydration, 250 to 500 ml per hour, unless patient had some severe cardiovascular, renal, or other comorbid factors. So acute pancreatitis, you can start them 250 to 500 ml per hour, LR, lactated Ringer solution, until unless any contraindication. If someone had a ejection fraction like 10% with severe congestive heart failure or renal failure, is a different story. Most beneficial during the first 12 to 24 hours. If you can give the aggressive hydration within the 12 to 24 hours of the onset of symptoms, you can prevent, the necrotizing pancreatitis. And, and fluid requirement should be reassessed with an hematocrit and BUN. Very simple. Within 6 hours, repeat the BUN or hematocrit. See, hematocrit will fall down with IV fluid. Initially you will see the hematocrit is about 50 or 48. It's because they're hemoconcentrated. I just repeat an hematocrit in 6 hours, and if they're below 45, then I see that adequate hydration was given, and we cut down the fluid level to maintenance, 150 ml. but we started 250 to 500 ml. If someone had severely dehydrated, we given 1 liter of bolus can also be given. So IV fluid is the treatment of acute pancreatitis. By all means, this is the only treatment. So failing, again, that same slide, failing to prevent necrosis, aggressive intravenous hydration. Third point is, does your patient need ERCP? As I said, you will find out which patient had, biliary pancreatitis. So as I mentioned, if the LFT is more than 3 times of normal, there is a strong suspicion the patient had a stone in the bile duct. And we can also see the stone in common bile duct by any means, sonogram, CT, MRCP, EUS. And if there is biliary sepsis, if the patient develops cholangitis, so that ERCP needed to be done, as because those patient needs urgent ERCP. There are 2 landmark papers. One is in Lancet, UK group, another one in America, New England Journal of Medicine. They all found that if the ERCP is done within 24 hours in biliary pancreatitis, it helps. But if it done, say, after 72 hours, it doesn't help. So if the patient had biliary pancreatitis, so ERCP needs to be done within 24 hours. It is helpful. After 72 hours, it didn't show any significant improvement. Fortunately, 50% of the patient actually gallstones is small. They pass by itself, and we don't need to do ERCP, in those patients. Fourth point, the errors happen is role of antibiotic. This is no longer debated, It was a trend, even in America, everybody with acute pancreatitis used to use them IV Cipro and IV Levaquin. So there is a double-blind placebo-controlled study was done, more than 32 centers with 100 patients, and has been found that prophylactic antibiotics are not recommended in acute pancreatitis. So no antibiotic in acute pancreatitis is the rule of thumb, If you give antibiotic, actually you are inviting troubles and they will develop, infection in the pancreas. I will come later on. Now I'll talk about the alarming disease that is the pancreatic fluid collection or necrotizing pancreatitis. Again, we did need to define that disease very well. We did a symposium and revised Atlanta classification, we call them, regarding the definition of acute pancreatitis fluid collection. So there are 4 terminology has to be well defined: acute fluid collection, acute necrotic collection, A and C. So when in acute pancreatitis, you have only these 2 conditions. Either has to be acute fluid collection or acute necrotic collection. And there are 2 terminologies, pseudocyst and walled off necrosis, WON1. It's very important, it is developed after 4 weeks. So at the beginning, you cannot call that the patient has a pseudocyst. You cannot call the patient has a walled off necrosis. You can only call acute necrotic collection or acute fluid collection. Say there is these slides will define it more. Like acute pancreatitis, as I said, 85% of the acute pancreatitis is interstitial pancreatitis. Only 15% developed necrotizing pancreatitis. So interstitial pancreatitis may cause some fluid collection around the pancreas, so we call them acute fluid collection. When the patient develops necrotizing pancreatitis, they can cause acute necrotic collection. So it's not only fluid, it is fluid plus necrotic material around the pancreas. So what is the rule of thumb? The red line here put, don't do anything, just wait 4 weeks rule. Let mature the wall. So acute fluid collection, they will develop a wall, only then we'll call them pseudocysts. So it is a time frame, 4 weeks, then the pseudocysts develop. Pseudocysts cannot happen in acute pancreatitis after 4 weeks. When the necrotic collection have a wall, we call the WON, walled off necrosis. It is both fluid and necrosis. And the red line is, don't intervene those patients for 4 weeks. Don't get panicked, just do conservative management. If you do intervention before 4 weeks, you are inviting trouble, you are putting the mortality. So 4 weeks rule, let's mature the wall, Don't do any intervention, no antibiotic, even with acute necrotizing pancreatitis, until unless you have documented infection. This is the CT to show the difference, what is pseudocyst look like. You see, it's only pure fluid in CT, but when wall of necrosis, you can see there is fluid, plus there is some necrotic material. So you can differentiate that two conditions. You see the dark fluid on CT scan, and WON is like hypodense material with fluid. This is a wall of necrosis. Again, the management of pancreatic fluid collection, I use the terminology 3D, acute fluid and necrotic collection, delay for 4 weeks. Don't do anything. 1D is delay. Then if the patient develops pseudocyst after 4 weeks, we drain them. Second D is drain. Wall of necrosis more than 4 weeks. The third D is debridement. So delay, drain, and debridement. Initially for 4 weeks, we'll delay any intervention, and then we'll drain and debride. There is another landmark paper. I always mention that this is a surgical paper. Surgeon did that. Why the delay things came? You see this slide, it is a randomized control, very difficult study to do, necrotizing pancreatitis randomized study. And mortality rate within the early intervention, less than 2 weeks, is 56%. And when after 4 weeks, there is a 15%. So if that's why I said 4 weeks rule is don't do anything for 4 weeks. It's because 56% mortality rate. Can you define any disease that half of the patient will die? So this is a very dreadful disease. It develops just from an ERCP or inadequate fluid management, and 56% patient may die. So no intervention for 4 weeks, for God's sake, and still you may lose 15% of the patients. So mortality rate in necrotizing pancreatitis is very high. In currently acute coronary syndrome, we don't have 50% death in America. But in acute necrotizing pancreatitis, you may lose 56% of the patient. So, but this rule only apply, if the patient does not have any infection. Necrotizing pancreatitis, if you start them TPN, if you start them, antibiotic, they may develop infection. That's why I said no antibiotic at the beginning until unless you have the features. See, you have a CT scan, they may show some gas, in the pancreatic collection. That means there is a gas-forming infection. If the patient continue to have high fever, chills, leukocytosis, gas bubble, persistent pain, or they cause obstruction, I do have to do drain if the patient had the fluid collection, compress the duodenum, or compress the outlet, gastric outlet obstruction, or they may cause compartment syndrome. I had a couple of patients from necrotizing pancreatitis. They developed so much pressure, their abdomen was rigid, necrosis, even ischemic bowel happens from compartment syndrome. So those group, we need to intervene immediately. We need to start them, antibiotic, and size is not an indication for drainage. If the patient had any of those features, we need to drain them. The 4 weeks rule does not apply in this group. And how do you drain? These days is very simple, We had the stent, I think is available in Bangladesh also, for pseudocyst drainage, we call it Axios stent, endoscopic cystogastroscopy. It takes 15 minutes, but it has to be done with EUS. We do EUS, we mark an area in the stomach or duodenum, then we puncture and put on a stent. It has a 2 flange, one flange opened inside the cyst, another flange open inside the stomach, and they are posed together. And we can do that. In pseudocyst, usually needs 1 session. In necrotizing pancreatitis, like WON, we may need multiple sessions. After putting the cyst, we can go through with the forceps to remove the necrotic material, and usually irrigate with hydrogen peroxide fluid to remove that. And it is a very simple procedure, and it's easily done. So now I will say if the patient had infectious, which antibiotic you'll use, Penicillin has 0 penetration in pancreatic infection, Actually, carbapenem group is the antibiotic of choice. Imipenem, meropenem, carbapenem has been shown to be most effective. But Cipro and metronidazole is also a good alternative. They had more than 90% penetration in the pancreas, and carbapenem group has 100% penetration. Penicillin has no penetration into the pancreatic tissue. So if you have to use antibiotic, choose antibiotic accordingly. So the final point, in the management is the mismanagement, I would say the nutrition. Is a tradition, historically, we think, acute pancreatitis patient, keep them NPO, give the rest to the pancreas, which is an obsolete thing. Bowel rest actually bad. Bowel rest cause intestinal mucosal atrophy and increase infectious complication. A study did show that if you give them prolonged bowel rest, the bacteria, small intestinal mucosa turnout is very fast, the epithelial cells. If you give bowel rest, their turnout slowed down and the bacteria translocate through the wall and actually cause infection. So oral feeding in acute pancreatitis has to be, started, and a study did show if you start early oral feeding, they have a shorter hospital stay, decrease infectious complication, decrease morbidity, and decrease mortality. So if the patient, as I said, you have to stratify whether your patient has a mild acute pancreatitis. If the patient has a mild acute pancreatitis, I start oral feeding within 12 hours and with a clear liquid diet and advance with low-fat diet first day, If the patient has severe or moderately severe acute pancreatitis, they will not tolerate enteric feeding. You have to, oral feeding. You have to give them enteric feeding. And this is another landmark paper was done, in America, is to be put everybody on TPN in severe acute pancreatitis. Then, this is a randomized study done between that enteric nutrition like tube feeding versus TPN. And in all parameters, it has been found that enteric nutrition is much, much superior than TPN. TPN is almost obsolete in the management of acute pancreatitis. So nutrition in moderately or severe acute pancreatitis, we can start NG along NJ feeding. This is also another study, nasogastric tube or nasojejunal tube. No advantage was seen between. So if your patient, they start with a nasogastric tube, if they don't tolerate nasogastric feeding, then get with nasojejunal tube. Nasojejunal tube is expensive. Nasogastric tube may cost extra taka, about $5. Nasojejunal tube is like a $1,500. You need radiology, fluoroscopy, and NIH is conducting a trial now, multi-center trial, comparing NG tube and NJ tube, nasojejunal feeding in severe acute pancreatitis, which is underway nationwide. Then, if the patient has acute pancreatitis, biliary pancreatitis, when to take the gallbladder out. This is also the recommendation is if the patient had mild acute pancreatitis, remove the gallbladder at the same admission, as because they may come back with another attack of biliary pancreatitis. If the patient has necrotizing or severe acute pancreatitis, you need to wait maybe 2 to 3 months before you take the gallbladder out, as because you need to get the necrosis and pancreatitis healed in those patients. Despite doing all this, the most sad part is the mortality rate in acute pancreatitis. Overall, is 6% patients die from acute pancreatitis in America. Interstitial pancreatitis only 3%. If the patient developed necrotizing pancreatitis, this study showed 17%. Previous study, I showed that 16%, so it's around 16 to 17%. If the patient has an infected necrotizing pancreatitis, it could be 30%. If there is a single organ failure, it is still like interstitial pancreatitis. Like if the patient may develop tachypnea or tachycardia, and they do very well. If the patient develops multi-organ failure, then 47% mortality rate. So, can you believe is a disease which can be triggered by a gastroenterologist or can be triggered by hypertriglyceridemia or a medication, and there is a 47% mortality rate in this disease with multi-organ failure. And this is also, very known paper, Paul Freeman and Peter Banks from Harvard both of my mentors, they did this study, and this is their conclusion regarding acute pancreatitis. So my message, do's and don't, I always say to my fellows, avoid labeling patient with mild during the first 48 hours, identify moderately severe acute pancreatitis patient, put them in the monitored bed, be aware of organ failure, maximize supportive care, prevent necrotizing pancreatitis, be generous with IV fluid, as I said, LR solution, start with 250 to 500 ml. If there is a stone in the common bile duct, do early ERCP within 24 hours if possible. Prevent infection. All necrosis is sterile. There is no bacteria in the peritoneal cavity. So even the necrotizing pancreatitis is sterile necrosis. Don't panic, but we prevent infection. Do not use prophylactic antibiotic. It has been shown using prophylactic antibiotics cause actually more infection in the sterile necrosis. Avoid TPN and start enteral feeding so the bacteria flows down to the bowel without translocation. So do not use prophylactic antibiotic, avoid TPN, and do the enteric feeding. If there is a sterile necrosis, like necrotizing pancreatitis, my 4 weeks rule, that conservative approach, supportive care for 4 weeks, delay the intervention. After 4 weeks, if they develop pseudocyst, we will put an axial stent drain. If there is a wall of necrosis, we will do the axial stent with debridement. If the patient develop infected necrosis, this is that 56% mortality group, begin antibiotic as well as and do the debridement. In some patient, we may have to use 3 groups, GI, surgery, as well as the interventional radiology. As because, we can remove only some portion, then it may go to the pelvis, even psoas area, they may need interventional radiology to put a drain there, that necrotic material. So this is a deadly disease, and I think most of these deaths in acute pancreatitis are avoidable if you follow these rules. That was my last slide, and thank you for your attention. I know it took a long time, but thank you for your patience and listening. Any questions? Or?
Assalamu alaikum, Riaz. Hi, can you hear me?
Yeah.
I don't know if you can see me. I'm Anindita. I spoke with you a long time ago. I'm good.
তুমি তো সান অ্যান্টনিওতে না?
জি, আমি সান অ্যান্টনিওতে। I have a couple of questions. জি, আপনি বলছিলেন। I have a couple of questions. You mentioned about the post ERCP pancreatitis and then use of indomethacin, which is an NSAIDs. And then also when we talked about the drugs that's causing pancreatitis, NSAIDs is one of those. So the question is, does it make the pancreatitis, what's the mechanism of indomethacin being NSAIDs preventing post ERCP pancreatitis when that could be another cause of pancreatitis? That's my question.
Yeah, that is a very good question. NSAID-induced pancreatitis is like, idiosyncratic reaction. And if someone had that, I think most of the patient had NSAID as the lifetime, and NSAID-induced acute pancreatitis, it definitely happened, idiosyncratic reaction. And, it is an, cause, but if the patient had no history of NSAID-induced pancreatitis, then I think it can be safely given. Someone, by the time ERCP, they must have some NSAID in their life, And so that is the dilemma. But a study did show, that it prevents. And the NSAID cause acute pancreatitis, if it doesn't happen so far, always they had NSAID in their lifetime. And if that happened, then we don't give those groups.
Okay. Another question I have here in US, a lot of people use herbal products like, supplements, and then they see commercials on the TV and they start, using all the drinks or the formula. Any association of any of the herbal products or supplements with pancreatitis? Have you seen any?
As I said, the drug-induced pancreatitis, you have to re-challenge them, with the drugs to cause that is a drug-induced pancreatitis. That's why it's very difficult. But so far, I don't have anybody herbal induced, acute pancreatitis or herbal products induced,
Okay. And another is, how do you manage pancreatitis in hypercalcemic patient with malignancy?
The hypercalcemia control and the acute pancreatitis management will remain same, IV fluid, analgesia, and control the hypercalcemia with malignancy. If there is a hypercalcemia is secondary to malignancy or hyperparathyroid disease, we focus on those disease. But, just a control like hypercalcemia with insulin or other mechanism is the right way. But you rarely see hypercalcemic pancreatitis these days,
Okay.
But there is just a control hypercalcemia with the routine way. There is no other specific management and follow the acute pancreatitis management.
Okay. Well, those were my questions. Thank you.
Thank you, Anita. Good to see you.
Yeah, same here.
Any other questions?
Am I audible, sir?
Yes.
It's me, Dr. Kamaluddin Sohel. I have a query, sir. First, you have said that indomethacin to prevent the post ERCP pancreatitis. Is it fixed for indomethacin? If indomethacin is not available, is there any alternative drugs? And if is it better to give before ERCP? Some authors says that giving rectal indomethacin before 30 minutes of the procedure, and some says that it will better after procedure.
Yeah, the study I mentioned, the New England Journal of Medicine, they did within 30 minutes of the procedure, and it was indomethacin formulary. So other NSAIDs may be used or not, I cannot comment on that. I use indomethacin suppository. It's very cheap, you have to prepare through your pharmacy so they can make that suppository. And it, as I said, there are a study they showed, before. There are also studies showed during the procedures, but if you do the supine position ERCP, it's difficult. I usually do immediately after procedure. And the original study did show immediately after procedure, but there are centers they are doing before, they're doing, during the procedure, and no significant difference has been found in any of those methods.
Okay, sir. Thank you, sir. Thank you very much.
So if there is no other question, can we conclude or?
So thank you for your excellent presentation. I have a question. Sir, which analgesic do you prefer?
The analgesic, is usually they need strong analgesics, We use like diluted. I use the IV diluted for the pain, 1 to 2 milligram Q 4 to 6 hourly. And, morphine can also be used, although someone said that morphine may cause a spasm of the SOD, sphincter of OD, but usually morphine also works very well. So either morphine or IV diluted, use. I don't use fentanyl or other stuff anymore. So these are my two preferred, IV diluted or morphine. Thank you. Thank you, Shabaki.
Thank you, sir. We can leave now.
Thank you, sir.